Welcome to USMLE Test and Discussion Series on Dermatology. Now we are discussing Case 2. So, a 22-year-old woman comes to the office due to several years of persistent facial blemishing. A 22-year-old woman who has blemishing. She has failed to respond to over-the-counter treatment. The patient has no other medical conditions. She does not use tobacco, alcohol, or illicit drugs. Skin examination findings are shown in the image below. Which of the following is the likely factor contributing to the pathogenesis of this patient's skin condition? You are given this image and you are given these options. So clearly when you read this question, they are asking you about the pathogenesis of this condition and you are required to identify which condition is this and then to know what is the pathogenesis of this condition. What are the options? Androgen induced involution of sebaceous glands, bacterial degradation of apocrine gland secretions, estrogen stimulated secretory function of sebaceous glands, increased desquamation of follicular epithelial cells, and proliferation of lipid utilizing bacteria within the pilosebaceous follicles. So what do you think is the right answer? So right answer is the last one. Proliferation of lipid utilizing bacteria within the pilosebaceous follicles. So the image shown to you in this question is the image of a disease called acne vulgaris. You can see that the patient has red papules, the patient has pustules and scars on the face, and this is consistent with acne vulgaris. Acne vulgaris is a chronic inflammatory disease which is primarily involves the pilosebaceous follicular unit. The classification and the grading of acne vulgaris is done by a classification called Pillsbury classification, which also helps you to learn the morphology of acne vulgaris, how it manifests. So grade 1 is primarily a comedonal acne. You will see comedones and occasionally one or few papules. Grade 2, you would see things which you see in grade 1. In addition, you would see more of papules. Comedones you would see because they are seen in a lesser grade also, and you would see fewer pustules. So you would see comedones, papules and few pustules. Grade 3, you will see things which are seen in grade 1 and grade 2, which are comedones, papules and pustules, but here there would be more of pustules, predominantly pustular, and then you would see few nodules and abscesses. In grade 4, you would see many nodules, cysts and abscesses, and you would see widespread scarring. Let me show you some images to make it more clear. So this is grade 1 acne. You can see comedones here. The images on the top are closed comedones. They are also called white head in local language. So these are closed comedones, and the images at the bottom are black heads, also called as open comedones. This is an image of primarily papular acne. Of course, there are some comedones here and there, and there are some other lesions like scars, but primarily papular acne. Then image here is an image of pustular acne. This is nodules which you can see. So this is a patient of grade 4 acne. You are seeing cyst on the other image. So these are both grade 4 acne. Now moving to the pathophysiology of acne vulgaris, there are 4 principal factors which are involved in the pathophysiology of acne vulgaris. The primary site of involvement is the pilosebaceous follicle, which is right here. So this pilosebaceous follicular unit is present extending right from the epidermis to the dermis. This is the epidermis, this is dermis, this is the hair follicle, and this is the sebaceous gland attached with it. The sebaceous gland is producing sebum. Okay, it has got receptors for androgens. So androgens act on these receptors on the sebaceous gland. This leads to increased sebum production, which you can see here. Also, this leads to colonization by P. acnes. P. acnes, Propionibacterium acnes, lives in the sebaceous gland. It proliferates. It starts producing inflammatory mediators. So there is release of mediators of inflammation. And eventually there is excessive sebum production. This sebum comes in the orifice. Along with that, there is altered keratinization. So these products get deposited here in the follicular unit, leading to occlusion of the pilosebaceous follicle by the keratinous plug. So these are the 4 principal parts in the pathogenesis of acne vulgaris, and there is no such thing as which is the first, second or third or fourth. All are interlinked, and this is a vicious cycle. One leads to the other and the other leads to the first. So in no particular order, there is altered keratinization within the follicle leading to comedone formation. So there is excessive desquamation plus sebum products which obstruct the pilosebaceous follicular unit. There is colonization of P. acnes within the sebaceous gland. These P. acnes leads to production of release of inflammatory mediators into the skin. There is excess sebum production by the sebaceous gland, which of course leads to proliferation of P. acnes, which of course leads to altered keratinization. Altered keratinization leads to occlusion of the pilosebaceous follicle. So you see, these are the 4 points which are all interlinked and lead to pathogenesis of acne vulgaris. So increased androgen production leads to increased sebum. Abnormal keratinization and desquamation obstructs the pilosebaceous duct. P. acnes proliferation in excess sebum leads to breakdown of sebum into free fatty acids. Pro-inflammatory mediators are activated and result in inflammatory acne. The second option was bacterial metabolization of apocrine secretion contributing to body odor. So you see, other than the sebaceous glands, there are 2 other types of sweat glands. You have apocrine glands, you have eccrine glands, and there is a specialized another type which is the apoecrine gland. So bromhidrosis is a condition characterized by excessive and offensive odor due to the excess of apocrine secretion. Option 3. Estrogen has anti-androgenic effects and inhibits sebum production. For this reason, we take estrogen containing oral contraceptives to improve inflammatory acne. So this estrogen is actually given as a treatment to treat hormonal acne. Hormonal acne manifests as acne along the jawline or along the beard area, and this estrogen has anti-androgenic effects, and in fact it inhibits sebum production. So this is not a cause of acne, rather it is used as a treatment of acne. Moving to option 4. So option 4 was whether excess of desquamation is actually leading to acne. No, this is a form of treatment of acne. So you see, when epithelial stem cells undergo mitosis in the basal layer of the epidermis, newer cells form and undergo differentiation as they migrate towards the surface. So these replace epithelial cells that desquamate. So there is always a desquamation going on. Increased epithelial mitosis and desquamation, that is topical retinoids which are used as a treatment, they lead to increased desquamation. So this increased desquamation helps to get rid of the debris which is actually accumulating and causing occlusion of the orifice. So it extrudes the debris from the comedones and helps to get rid of the comedones. So it is a treatment of acne, not a pathogenesis of acne. So what is the educational objective for this case? So acne vulgaris or acne is characterized by the obstruction of pilosebaceous follicular units. The first morphology of lesions which is formed is the comedones due to the obstruction of these pilosebaceous units. There is hyperkeratinization, excess sebum accumulation. Androgens stimulate production of sebum, which serves as a nutrient source for P. acnes. Within the follicles, P. acne proliferation triggers an inflammatory response, resulting in formation of red papules and pustules.